Welcome back to the RHS on the PW MedEd. I'm Dr. Patil, and today we will be discussing about the pleural effusion. Many of you had requested me to do this chapter because your university exams are nearby, and pleural effusion is a theory question as well as your practical question. So we'll try to address both what can be asked in theory as well as what can be asked in practical. At the same time, we will also keep in mind the commonly asked areas of MCQs for the NEET, PG, FNM, FMG, and INICET. So let me begin with defining pleural effusion. What is pleural effusion? We know that there is a pleural space. In that space means there are two layers of pleura, one which is adherent to the lung, we call it as visceral pleura, and one that is separated it called as parietal pleura. Between that there is a space. There is some amount of fluid which is normally around 5 to 15 ml, maximum 20 ml. Anything more than that is abnormal. So abnormal collection of fluid in pleural space is what we are going to call as pleural effusion. So what is pleural effusion? Abnormal collection of fluid in pleural space. Now what causes the collection of fluid in pleural space? That's what we need to learn. Abnormal collection of fluid in pleural cavity or pleural space is our pleural effusion. What causes it? Now the fluid, if it is coming into the pleural space, it is mostly coming from blood vessels, because that's what brings the fluid to every part of the body, right? Every tissue receives the fluid or plasma from the blood vessels. So when blood vessels bring the blood, normally what happens, inside the blood vessel there is a force which wants to push the fluid out from the blood vessels, and there is a force which wants to retain the fluid in the blood vessel. So we'll first try to understand that force, and then we will get back to the pleural effusion. So at the level of tissues, including, right now we are talking about the pleura. So at the level of pleura, pleura is basically a tissue. On one side, the blood comes to this from the arteries and then exits through the venules. So we have arterioles and venules. On one side, we have arterioles, which is bringing the oxygenated blood to the tissues, and we have venules, which is taking away the deoxygenated blood from the tissues, and interposed between these two we have what we call as capillaries. We have capillaries. So let us say the black here is representing capillaries. So these are, in between these we have capillaries. In between the arterioles and the veins we have capillaries, and when you look at the capillaries have small openings called as fenestrations. These openings are called as fenestrations, which allows the movement of water molecules between the interstitium and the blood vessel. So through these, small molecular weight substances and water can all move out or come back into this space. The force that wants to drive the fluid out is called as hydrostatic pressure. Hydrostatic pressure wants to push the fluid out from these capillaries into the interstitium, if I'm talking about the pleural space, into the pleural space. And the force that wants to retain the fluid inside will be called as oncotic pressure. Oncotic pressure. Now what is this hydrostatic pressure? Hydrostatic pressure is pressure, the blood pressure inside this capillary. More the pressure inside the capillary, more is the hydrostatic pressure that wants to push the blood out or push the fluid out. What is oncotic pressure? Oncotic pressure is primarily the pressure which is trying to retain the fluid inside, and it is dependent on the large molecular weight substances in the blood, mainly albumin. Albumin is the most important factor determining the oncotic pressure. So albumin wants to retain the fluid inside the blood vessel, and the blood pressure of these capillaries wants to push it out. Anytime I have an imbalance, the water may leak out and stay in the interstitium. What imbalance I can have? I can have increase in hydrostatic pressure or decrease in oncotic pressure will lead to fluid leaking into the tissues. When the fluid is leaking into the tissues, including the pleura, the fluid is primarily leaking from these so-called capillary fenestrations. So can I pass on the large molecular weight substances through this? No. Most of the proteins that are there in our circulation or blood are large molecular weight substances. So they will not diffuse through this. So one that is going into the interstitium, that fluid will primarily contain water and low molecular weight substances. Indirectly, can I say that this fluid which is going out through these fenestrations because of imbalance in oncotic or hydrostatic pressure is not having much of protein. It has minimal quantity of protein because protein cannot pass through it. Yes. So this fluid we will call it as transudative fluid. So any condition which is causing this are causes for transudative effusion. So on one side we will have causes for effusion classified as transudative effusions, and transudative effusion primarily happens because of, it is usually due to imbalance between hydrostatic and oncotic pressure. Imbalance between hydrostatic pressure and oncotic pressure. So there are plenty of conditions where you will have increased hydrostatic pressure. When do I get increase in the hydrostatic pressure? What will happen if I increase the circulating blood volume? The volume of blood going to these capillaries is increased. Hydrostatic pressure will increase. So any condition where I retain a lot of fluid inside my blood vessels, hydrostatic pressure will increase. So can I have increase in hydrostatic pressure in heart failure? Yes. Why will I have increase in hydrostatic pressure in heart failure? So as heart fails, stroke volume decreases. To compensate for that, because stroke volume decrease means BP starts decreasing, and to compensate for that, RAS gets activated. RAS brings aldosterone. Aldosterone will increase the sodium and water reabsorption. So blood volume will increase, hydrostatic pressure will increase. Similarly, if I have cirrhosis of liver, I think we have discussed in the previous class also when we spoke about the CLD. Whenever there is cirrhosis of liver, there is portal hypertension, and again there is activation of RAS. So hydrostatic pressure can increase in conditions like chronic congestive cardiac failure, that is heart failure, then chronic liver disease or cirrhosis of liver. And when there is kidney failure, hydrostatic pressure will increase. Why? Because kidneys are not able to excrete the water out. Water stays in the blood, so blood volume swells, hydrostatic pressure increases. So in patients with chronic renal failure, in all these cases, we are expecting to see pleural effusion because of increase in hydrostatic pressure. When can I have decrease in oncotic pressure? That can also cause, decrease in oncotic pressure can also cause fluid to leak out from this space and go into the interstitium. How do I decrease the oncotic pressure? I have to decrease the albumin. So when do I have decrease in the albumin? Decrease in the albumin can also occur in CLD. So decreased oncotic pressure is equal to decreased serum albumin. The serum albumin can decrease in patients with, one of the cause I can quote here is chronic liver failure or cirrhosis of liver. There is decrease in albumin. Then I can have decrease in albumin in patients with nephrotic syndrome. Now, why am I losing albumin in nephrotic syndrome from my blood? Because at the level of kidney, there is proteinuria at a very high range, 3.5 grams per day or higher than that. So we have nephrotic range proteinuria. I can also have decrease in albumin. See, remember, when cirrhosis, we are having decrease in albumin because albumin production is the job of liver. In nephrotic syndrome, we are having serum hypoalbuminemia because liver is doing its job. It is producing sufficient albumin, but I'm losing it in urine because of the failure of the kidney. Nephrotic syndrome is the reason. Okay, but apart from this, there is one more cause where albumin can go low, and that is decreased intake of protein. Liver is fine, it can make albumin. Kidney is fine, it will not lose albumin. But to make albumin, liver needs the essential amino acids. If my food does not have these amino acids, I may not be able to synthesize albumin. What do we call that condition as? Protein energy malnutrition, mainly protein malnutrition. We also call it as kwashiorkor. We also call it as kwashiorkor. Raj Pandey, nephrotic syndrome is a condition in the kidney where there is damage to the glomeruli, and because of that we start losing protein in urine. Normally we should not lose large amount of high molecular weight proteins, but we start losing. We may lose up to 3.5 gram of protein in the urine per day. Because of that, the blood albumin level decreases, because whatever albumin is there in the blood is all being lost in the urine. Kwashiorkor is a condition where my intake of protein is decreased. Because of that, my production of albumin in the liver is decreased, so my blood albumin is low. In all these cases, oncotic pressure is decreased. So when I have a force that drives, like there is a usual balance between a force that wants to drive the fluid out and the force that wants to keep the fluid in. The force that wants to keep the fluid in is albumin, the force that wants to drive out is hydrostatic pressure. अगर मैं हाइड्रोस्टैटिक प्रेशर बढ़ा दूंगा तब भी फ्लूइड लीक होके टिश्यूज में जाएगा, या ऑन्कोटिक घटाऊंगा तब भी फ्लूइड लीक होके टिश्यूज में जाएगा. So all of them will cause transudative effusion. Why is it transudative? Because यहाँ पे जो fluid tissues में जा रहा है, it is mainly passing through these capillary fenestrations. It will not contain large amount of protein. It will contain mainly water and some electrolytes, small molecular weight substances. So transudative effusion means fluid which is not rich in proteins. But think about it. What will happen if I cause damage to these capillaries, and then fluid leaks because of the damage to capillaries? The fluid that is leaking is not only containing water, electrolytes and small molecular weight proteins, it will also contain large molecular weight substances like albumin and other proteins. Normally in imbalance, we are only losing through these capillary fenestrations. So we are not losing high amount of protein. But if these capillaries are damaged, I lose high amount of proteins. When do I get these capillaries damaged? Whenever there is inflammation. For example, we are now talking about pleurae. So if I cause inflammation of the pleural capillaries, they can get damaged. So I can leak out protein rich fluid into the interstitium or the pleural space, right? So that kind of effusion where there is inflammation involved, and inflammation is making us lose large molecular weight substances including protein, that kind of effusion we are going to call it as exudative effusion. So exudative effusion is the effusion which is rich in protein. We will call it as exudative effusion. So one set of causes are transudative, the other set is exudative effusions. In exudative effusion, it is not because of the imbalance between hydrostatic and oncotic pressure. It is usually due to inflammation. And exudative effusion is protein rich fluid which is effusing into the pleural space. Transudative mein low protein fluid is going into the pleural space. So this is low protein fluid. But in exudative, there is a protein rich fluid which is going into the pleural space. Now what can cause this? The causes for exudative. Transudative we classified based on whether hydrostatic pressure is increased or oncotic pressure is decreased. But for exudative, I want you to remember only one point. Any condition where itis or inflammation is involved, you should always think about exudative effusion. Any condition जहाँ पे inflammation involved नहीं है, कॉज में या तो हाइड्रोस्टैटिक प्रेशर इंक्रीज हुआ है या ऑन्कोटिक डिक्रीज हुआ है, यू शुड थिंक ऑफ ट्रांसुडेटिव एफ्यूजन. तो एक्सुडेटिव एफ्यूजन कहाँ पे मिलेगा? फर्स्ट थिंग इज पैरानिमोनिक एफ्यूजन. What do you mean by paranpneumonic effusion? The effusion that is happening along with the pneumonia. Pneumonia means infection is there. Infection means inflammation is there. Inflammation means inflammatory fluid is leaking which contains high amount of protein. So paranpneumonic effusion, also called as synpneumonic effusion. Paranpneumonic or synpneumonic effusion. Inflammation is there. Okay. Second, if there is tubercular pleuritis, inflammation of the pleura caused by tuberculosis. Inflammation is there, we will have exudative effusion, protein rich fluid. Paranpneumonic effusion and tubercular pleuritis. Then third, patients with rheumatoid arthritis are prone to develop pleuritis. Why they develop? Because in rheumatoid arthritis there is increased production of inflammatory cytokines like TNF alpha, interleukin 1, 6. They cause the inflammation of joints as well as various other tissues. Rheumatoid arthritis एक सिर्फ joint का disease नहीं है, it's a multi-system disorder. Pleura can also be affected. In fact, I also want you to remember that in rheumatoid arthritis, the most common respiratory manifestation of, मतलब most common respiratory system manifestation of rheumatoid arthritis is going to be pleuritis. So rheumatoid arthritis is a multi-system disorder. It can affect the respiratory system also. Inside the respiratory system, pleuritis is its most common manifestation. So when there is pleuritis, itis is there, means inflammation. Inflammation is equal to exudative effusion. So in rheumatoid arthritis, associated pleuritis, you will have exudative effusion. Similarly, SLE is also known to cause pleuritis. So SLE associated pleuritis, we will have exudative effusion. So simple, easy to remember है the causes for transudative and exudative. Whenever the causes open in front of you, बस आपको इतना ही सोचना है कि इस कंडीशन में क्या हाइड्रोस्टैटिक ऑन्कोटिक प्रेशर का इम्बैलेंस है तो इट विल कॉज ट्रांसुडेटिव एफ्यूजन. वेयर वी गेट दैट? ऑर्गन फेल्यूर्स एंड लो एल्बुमिन. ऑर्गन फेल्यूर्स में हाइड्रोस्टैटिक प्रेशर इंक्रीज होता है, लो एल्बुमिन में ऑन्कोटिक प्रेशर डिक्रीज होता है. तो क्वाशियोर्कर देयर इज लो एल्बुमिन, नेफ्रोटिक सिंड्रोम देयर इज लो एल्बुमिन, सिरोसिस देयर इज लो एल्बुमिन. Organ failure, there is increase in, because blood volume increases, there is increase in hydrostatic pressure. Whenever you think of inflammation, pneumonia, infection is inflammation. Pleuritis, inflammation. Pleuritis, inflammation. Pleuritis, inflammation. You should think of exudative effusion. So now that we know about the causes for the effusion, let us see what are the clinical features that we are going to expect in these patients. So what is pleural effusion? Abnormal collection of fluid in the pleural cavity is pleural effusion. This can happen either because of imbalance between oncotic and hydrostatic pressure. Such fluid will be low in protein because fluid is not leaking through injured capillaries, it is leaking through fenestrations. It will not have high molecular weight substances like protein. That fluid is called as transudative. So it can happen because of high hydrostatic or low oncotic pressure. And if there is inflammation, there is injured capillary through which inflammatory exudative fluid is leaking, that will be protein rich. So that fluid will be called as exudative fluid. Wherever you have itis or inflammation, you should think about exudative. Now, whether it is because of imbalance in hydrostatic pressure or oncotic pressure or the inflammation, fluid is accumulating in the pleural space, patient will present with some symptoms related to that. So let's see what symptoms they can present. If there is only minimal quantity of fluid accumulated, the patients will generally present with asymptomatic picture. They will present with asymptomatic picture because thoda sa hi fluid hai, it's not going to cause any compression or anything. But if there is massive effusion, we will definitely get symptoms. What symptoms we are going to get? We'll try to understand that by looking at what happens to the fluid accumulation. So now you only tell me, when fluid is accumulating, Mayankraj, yes, SLE is systemic lupus erythematosus. वो एक autoimmune disorder है where body is producing antibodies against our own tissues and they are causing the damage to tissues, and one of the tissue that is getting damaged is also pleura. It is getting inflamed, so we will have inflammation and we end up with exudative effusion. Okay. Now as the fluid accumulates, you tell me whether the fluid will accumulate at the bottom of the pleural cavity or at the top. Fluid hai, gravity hai, so it will always accumulate at the bottom. If it was air, it is light, so it ascends up. So air would accumulate more at the top. If I accumulate air in the pleural space, it will accumulate relatively more at the top. But if it is fluid, it's more at the bottom. Okay. So this is my pleura. This is the lung that we are looking at, and we know that there are two layers of pleura. One is adherent to this lung, that is called as visceral pleura. Outer pleura, which is separated from the lung, is called as parietal pleura. Between this is what we have as pleural space or pleural cavity. This is our pleural space or pleural cavity. So accumulation of fluid in this is our pleural effusion, and as I start accumulating the fluid, it is going to collect more at the bottom. So I start accumulating the fluid here, and as I start filling the fluid in this space, what will happen to the lung? Lung gets pushed up, and this lung is a spongy tissue. So as I start pushing this lung up, being a spongy tissue, what will happen to this lung? So let me sketch it one more time. The iPad is not responding. So basically this is my trachea. This is my lung. Lung will have a visceral layer, and separated from it I will have a parietal layer, and I start accumulating the fluid in this space. As I start accumulating the fluid in this space, the fluid will exert a pressure on the lung, and as it starts exerting the pressure on the lung, it will start lifting the lung up, and as it is lifting the lung up, lung being a spongy tissue, its bottommost part gets compressed or collapsed. So the bottom part of the lung will start getting collapsed now because of this fluid's pressure. And one more thing we should know is that whenever fluid accumulates in the pleural space, for some unknown reason, though there are various hypotheses to explain this, fluid appears to ascend up towards the axilla. One of the explanation that old generation doctors give is this is because the capillaries in the axilla have capillary action, so they are creating a suction force, that's why fluid is going up. So ये एक hypothesis है. Second hypothesis is just a uh, distorted appearance and there is no such ascent of fluid into the axilla. So the fluid is accumulating, we will have more fluid going towards the axilla, at least it appears so. But yes, one thing is clear that this fluid is pushing the lung and the lung is going to get collapsed. Which part will get collapsed? The bottommost part. This lung will get collapsed under this pressure. So as this lung collapses, the air from this alveoli in this area is all replaced now. It's all gone. It's all solidified now. So now on one level, I have pleural effusion or pleural fluid. So this level there is pleural fluid. But just above the pleural fluid, there is a collapsed lung. The lung got collapsed. We will call it as collapse consolidation. Consolidation means lung becoming solid. It is solidified. Earlier, it was all air-filled alveoli. I have compressed it. Air is gone. It is now solidified. So we'll call it as collapse consolidation. It is collapsed and solidified. Okay. Now, what happened is this much portion of the lung is not participating in the gas exchange because this all is collapsed. तो इसका काम किसी ना किसी को करना पड़ेगा. जब मेरे पास पूरा 100% लंग कैपेसिटी था तो मेरा काम ठीक से चल रहा था. I was able to do my task. I was able to oxygenate my blood. But now part of my lung is collapsed. So I want to extract the work of this collapsed part from the rest of the lungs. So what will happen now is just above this effusion, the alveoli will slightly get inflated so that they can have more air entering into them. So we will call that as, like simple से word में कहूँ तो ये collapse हुआ तो अब इसके ऊपर का थोड़ा सा लंग expand हो जाएगा या hyper inflate हो जाएगा. So just above this collapse we have a hyper inflated lung. So this portion is hyperinflated. It is hyperinflated to compensate for the work done by the collapsed lung. So we will call it as compensatory hyperinflation. Many teachers use the term compensatory emphysema. I personally prefer not to call it as compensatory emphysema because emphysema का एक definition है. What is emphysema? Emphysema is defined as irreversible dilatation of alveoli और acini, irreversible dilatation. तो यहाँ पे जो dilatation हो रहा है या hyperinflation या expansion हो रहा है, it is reversible. They are not irreversibly dilated. The alveoli are dilated but reversibly dilated. So when there is irreversible dilatation of acini or alveoli, we call it as emphysema. यहाँ पे irreversible नहीं है, that's why I would prefer to just label it as hyperinflation rather than calling it as emphysema. But अगर कोई teacher ये term use करता है practical exam में, it's perfectly okay. You can consider it as compensatory emphysema or compensatory hyperinflation. Okay, तो ये एक साथ हो रहा है. इसके साथ जैसे ही फ्लूइड और बढ़ता जाएगा इस स्पेस के अंदर, और क्या प्रॉब्लम हो सकता है? एज द फ्लूइड इंक्रीजेस मोर इन क्वांटिटी, लंग और कोलैप्स होगा, ये और हाइपर इन्फ्लेट होगा. इस हेमीथोरैक्स में प्रेशर इंक्रीज होता जा रहा है बिकॉज इन वन हेमीथोरैक्स फ्लूइड इज अक्यूमुलेटिंग, प्रेशर इज इंक्रीजिंग. सो दिस प्रेशर व्हाट इट विल डू, इट विल ट्राई टू पुश द mediastinum and the trachea to the opposite side. So we will have a force exerting the trachea to move to the opposite side. It will try to push the trachea to go to the opposite side. So trachea will become deviated. So what are the symptoms we are expecting? Some part of the lung is collapsed because of this fluid. This is not participating in the gas exchange. So I can have shortness of breath because now my lungs capacity is not sufficient for me. So one symptom we are expecting. On examination, I may notice that if the fluid is massive, large amount, the trachea may be deviated to opposite. So can anybody tell me how do I recognize whether trachea is deviated to opposite or not? Whether trachea is deviated to opposite or not. So let me know in the comments. I will anyway explain this. Now, I want to see what examination findings I'm going to get in these patients. So first we will start with the percussion. So when I start percussion, what findings I'm going to expect? Let me say I want to percuss here. What note I will get? When we percuss on the normal lung, what is the note that we get? The note that we get is called as resonant note, because lung is aerated tissue. The note that it produces is resonant. If I percuss on a hollow organ like stomach, intestine, the note that it produces is called as tympanic. When I percuss over the liver or any solid organs, including bones, my skull, it produces a note which is called as dull or flat note. Okay, so those who are not familiar, just let me write down the percussion notes that we should know. What are the percussion notes generally we get? So when I percuss over the normal lung is aerated, the percussion note is going to be what we call as resonant note. When I percuss over the hollow viscous or hollow organ like stomach or intestine, you can say most part of the abdomen which contains intestines and stomach, it will produce tympanic note. It will produce tympanic note. If I percuss over a solid organ like liver or spleen, it will produce a dull note. Okay, these are basic things we should know. Similarly, you should also know that if I percuss over fluid, fluid always produces a dull note. So now here I have so much of fluid. So if I percuss over the pleural fluid, what note I'm going to get? I'm going to get a dull percussion note. Earlier I should have got a resonant note because यहाँ पे lung हुआ करता था. There was a lung here, but now that lung is lifted up, fluid has taken its place. Over the fluid, wherever there is fluid, I will get a dull percussion note. Okay. Then whenever I percuss over a solid organ, what note I get? I get a dull note. So if I percuss over this consolidation, the lung is solid, तो यहाँ पे भी क्या note मिलेगा? I will get a dull note. I will get a dull percussion note. But if I percuss over the normal lung, what note I am going to get? A percussion over the normal lung. This is unaffected part of the lung. Normal lung. Normal lung is full of air. Percussion over the aerated lung produces resonant note. तो यहाँ पे एक resonant percussion note मिलेगा. So when we have pleural effusion, there are multiple layers in the lungs created. Bottom we have fluid, then collapsed lung which is solid, then air which is hyperinflated, more than normal amount of air in the lungs. Then we have normal amount of air in the lungs. So when I percuss over this normal area, I am going to get resonant note. When I am percussing in this all area, here because of fluid I am getting dull note, here because of solid lung I am getting dull note. But if I percuss over this hyperinflated lung, what note I am going to get? Trail sign is yes, tracheal shift. I'll come to that. Abhijit, good, very good. So when I percuss over this hyperinflated lung, hyperinflation matlab more air than normal. So normal air produces resonant note, more air will produce hyper resonant percussion note. We will have a hyper resonant percussion note. We will have a hyper resonant percussion note. Okay, this is clear. Now in this patient, because the fluid appear to ascend up in the axilla, when I go on percussing, what will happen to the level of dullness? It goes on increasing towards axilla. तो यहाँ पे यहाँ तक dullness का note मिलेगा. Here up to here I will get the dullness note. Here up to here, as I go towards the axilla, the level of dullness goes on increasing. So the level of dullness, upper limit of the level of dullness goes on increasing towards the axilla. और फिर if I go on go on percussing posteriorly, फिर से axilla से नीचे decrease होता दिखेगा. So the level of dullness goes on increasing towards the axilla, and then from the axilla posteriorly again it goes on decreasing. So it creates an inverse S-shaped curve, goes up, posteriorly comes down. So when you percuss from behind, the level will be lower. When you percuss anteriorly, level will be lower. But when you percuss in the axilla, the level is higher. lower anteriorly, higher posteriorly, higher in the axilla, again lower posteriorly. This, if I write down the upper limit एक line, तो it produces a inverse S-shaped curve, and इसको हम कहेंगे Ellis S-shaped curve. So one of the important examination findings that I want you to remember in these patients is we get something called as Ellis S-shaped curve. This is what your professors are going to ask in the bedside discussion. So what is this Ellis S-shaped curve? The level of dullness or the upper limit. Many of you may get confused when I say level कि हाँ इससे dull बहुत ज़्यादा dull है या कम dull है. No, the upper limit of dullness is what I'm referring to. The upper level of dullness increases towards axilla and it is lower anteriorly and posteriorly, creating an inverse S-shaped curve. We are going to call it as Ellis S-shaped curve. So that is first finding that we are going to get, which can be asked by your professors. Okay. Second, we now learnt about the percussion note. Now let us see what will happen to the auscultation. So when I do auscultation, what kind of sound we are going to get? And for again auscultation, I want you to know the conduction of the sound. Which medium is a better conductor of sound? Is the solid a good medium of conductor of sound, or air, or the fluid? Which is a better conductor of sound? So solid is a better conductor of sound. You may be wondering why is it? Sound is what? It's a wave. Wave means oscillation of particles. तब wave propagate होता है. तो particles चाहिए oscillate करने के लिए. Air में है कम particles, solid में है ज़्यादा. So because solid has more particles, it can be a better conductor of sound. Like, can sound go in propagate in vacuum? No, because वहाँ पे no particle to oscillate, so we can't like hear anything that the other person is saying. So like less the density of the air, less is the conduction of the sound. So air is less dense, solid is more dense. So in terms of conductor of sound, solid is a better conductor of sound, followed by air, and fluid is the worst conductor of sound. So you might have noticed it that when you are swimming and all, and when you are underwater, even if you are sinking, आप कितना भी चिल्लाओ, the person outside cannot hear because the fluid or water is not a good conductor of sound. Solid is the best, air is the next best. Okay, this is important for us to understand the auscultation findings. So here fluid is there, so sound that is coming from the lungs, this will not be able to conduct it. So what will happen here? We will have diminished breath sounds or absent breath sounds. So in terms of breath sounds, we will have diminished or absent breath sounds. Diminished or absent breath sounds. On the other hand, if I auscultate the normal lung where there is no fluid, lung is not collapsed, everything is fine, we will have normal breath sounds. And what do we call normal breath sounds as? Normal breath sounds are called as normal vesicular breath sounds. They are called as normal vesicular breath sounds. Now what do I mean by this vesicular breath sounds? If you guys have a stethoscope, I want you to take it and spend 2 minutes after the class auscultating over your sternum, trachea and chest. So if you keep your steth on the trachea and the sternum, you will hear some sound, and when on the chest you will hear some sound. You will notice the difference. When you keep it on the trachea or the sternum, you hear harsh sounds, but when you keep it on the chest, the rest of the chest apart from the trachea and sternum, you will hear soft sounds. Okay, so now why am I having this harsh over here and soft over here? We'll try to understand that. Remember, the sound is not produced by the movement of air through alveoli. Means as the, like, see, if you look at more detailed anatomy, this trachea will go on dividing through multiple branches. Eventually it becomes, finally it becomes alveoli, right? Finally it becomes alveoli. The movement of air through this acini alveoli is not producing the sound. Sound is produced by trachea and bronchi. The movement of air between trachea and bronchi produces the sound. So as air comes here, it starts making the noise. It starts making the noise here. आगे noise produce नहीं होता है. But the same sound gets conducted to our auscultating stethoscope. But as the air passes through the alveoli, it loses its harshness. Why is it losing? Remember, whenever you see anyone talking over mic and all, you might have noticed that the mics often have a tip, often has a sponge. Mics have a sponge. Why a sponge is placed on the tip of a mic? Because when someone is speaking, his voice contains harsh frequencies and soft frequencies, and we don't want the harsh frequencies to reach the listener's ear. Okay, what am I using? Sponge. So spongy tissue filters harsh frequencies. Lung is also a spongy tissue, right? These all alveoli that we have here, they are all basically, lung is a sponge. So sound is produced in the trachea bronchi, and as it passes through this spongy tissue, it loses the harsh frequencies and then comes to the stethoscope as soft frequencies. Actual sound is produced in trachea bronchi. So this sound that is produced in trachea bronchi, I will call it as bronchial breath sound. Bronchial breath sound. And the sponge of the lung filters it to make it soft, and that soft sound is what we call as vesicular breath sounds. Spongy nature of the lung is doing that filtration, and we are going to call it as vesicular breath sound. So have you heard a bronchial breath sound? You can hear it today. Place the stethoscope on the sternum, and here that is your bronchial breath sounds, because that sound is mainly coming from the tracheobronchial tree and not from the alveoli or that part of the lung. That is your bronchial breath sound, and whatever you hear on the rest of the lung fields is vesicular breath sounds. So normal lung is definitely going to give rise to vesicular breath sound. जहाँ पे फ्लूइड है कोई साउंड नहीं आएगा, we will have absent or diminished breath sounds. But what will happen in a place where there is collapsed lung? So sound is produced in the bronchial tree. It will come to this collapsed lung. Collapsed lung does not contain air, so this will not filter out the harsh frequencies. What is the sound produced actually? Bronchial breath sound. वो आएगा solidified lung में, यहाँ पे filtration नहीं होगा. So to my stethoscope directly unfiltered sound will come. तो इसको हम क्या कहेंगे? So the original sound, the same sound that is produced in the bronchi is coming to my chest without the filtration. Normally lung is aerated, so it filters, produces or converts the bronchial breath sound to vesicular. But यहाँ पे filter नहीं है, lung is consolidated. So directly I will get the same sound that is produced in the bronchial tree, and the lung is a good solid is a good conductor of sound, so it will come unfiltered in a very clear manner to my stethoscope. इस sound को हम कहेंगे bronchial breath sounds. So wherever there is consolidation, we will get bronchial breath sounds. In a pleural effusion case, ये कहाँ पे मिलेगा? Where do I get it? Just above the level of effusion, we get bronchial breath sound. We will get bronchial breath sounds. And then when I auscultate over this hyperinflated lung, वहाँ पे alveoli हैं, hyperinflated हैं, they will definitely filter down the harsh frequencies of our bronchial sounds to normal vesicular breath sounds. So here also I will get normal vesicular breath sounds. So now look at this lung. Bottom there is fluid which is dull to percuss, and breath sounds there are diminished or absent. On top of it, this fluid has collapsed a portion of the lung that has become solid now. So there being solid, I'll get dull percussion note. But if I keep the stethoscope there, I will get bronchial breath sound. The same sound produced in the bronchi coming to my stethoscope unfiltered, because there is no aerated alveoli there. Above that, I will get the normal vesicular breath sound on auscultation. But percussion just above this collapsed lung will give me a hyper resonant note. Will give me a hyper resonant note because यहाँ पे alveoli are hyper inflated. And this band of hyper resonance just above the pleural effusion, like this will be going up and coming down. This band of hyper resonance that is there above the pleural effusion, this band, we will also call it as Skodaic resonance. So second question that your teachers may ask you is, what is this Skodaic resonance? Skodaic resonance is a band of hyper resonant note. It's a band of hyper resonance above hyperresonance above the pleural fluid level. And what is the mechanism? What is it due to? It is due to compensatory emphysema or compensatory hyperinflation of the lung. What is it compensating for? Because pleural fluid made some part of the lung collapse. The remaining portion is inflated to compensate for the work done by the collapsed part of the lung. So compensatory hyperinflation is responsible for this hyperresonant note. We are going to call it as Skodaic resonance. So earlier I had asked, like if there is massive effusion, we are going to have the trachea deviated to opposite side. How do you get to know that? So as the trachea moves to the opposite side, like you can do this small experiment, take 3 fingers, push your trachea to the opposite side and observe what happened to the sternocleidomastoid muscle. As I push the trachea to the opposite side, the sternocleidomastoid muscle on the opposite side becomes prominent. So tracheal deviation to the opposite side may make the opposite side sternocleidomastoid muscle prominence, and that prominent sternocleidomastoid muscle, we have given a name for this sign. So trachea may be shifted to opposite side. Tracheal deviation to opposite side. And as the trachea deviates to opposite side, the sternocleidomastoid muscle becomes prominent. And this prominent sternocleidomastoid muscle is called as trail sign. So you may have trail sign positive when there is massive pleural effusion. Let me see if I have an image of a positive trail sign. Okay, yeah, I do get an image. So let me show you that image. So here, as you see on the monitor, you have an image which is showing a prominent sternocleidomastoid muscle. Can you notice that on this side? So trachea is shifted to that side. That's this side. So that's why you're seeing this prominent sternocleidomastoid muscle. The sternocleidomastoid muscle is being lifted by the shifted trachea. We call this as trail sign. It is called as trail sign. So let me keep that image here for your reference so that when you go through the notes, you should be able to remember this. The trachea is deviated to this side, means probably if this patient has pleural effusion, then it is going to be on the right side, which is pushing the trachea to the left, and this left sternocleidomastoid muscle is lifted and it is becoming prominent. We call this as trail sign. So that way you can identify that trachea is deviated. Another thing, when you try to examine this patient, like apart from seeing, when we do palpation, I can try to push my finger or invaginate my finger between the trachea and sternocleidomastoid muscle. तो इस साइड ट्रेकिया शिफ्टेड है, ये sternocleidomastoid lifted है. So I will find it difficult to invaginate my finger between the trachea and sternocleidomastoid on the side where it is deviated. But this side space is there, I can easily poke my finger. Like you can do this with your own hand, push the trachea to the opposite side and try to poke your finger between trachea and sternocleidomastoid. Possible nahi hoga, mushkil hoga. The other side, it is free, you can poke in. So that's how you can confirm that trachea is deviated. Most cases दिखते ही पता चल जाएगा कि trail sign है, sternocleidomastoid is lifted, so you know there is massive effusion which is shifting the trachea to the opposite side. So these are the examination findings. This is what will be asked in the bedside discussion. What is the note you get on percussion in the fluid? What is the note you get above the dull note? So fluid and solid is giving dull note. So the solid and fluid giving dull note, the level ascends up towards the axilla, then again posteriorly descends. We call it as Ellis S-shaped curve. And above this level of dullness, there is a band of resonance, hyperresonance. We call it as Skodaic resonance. On auscultation, what do you get just above the pleural fluid? Just above the pleural fluid, there is a collapsed lung, which is no longer filtering out the bronchial breath sounds to vesicular. It remains bronchial, so I get bronchial breath sounds, right? Okay, now these patients have come, we have examined, we have got these findings. I have to confirm it with investigation and then take it to the final diagnosis. So for the pleural fluid confirmation, what is the investigation of choice? Okay, so first we have to understand what all investigations we can do. So we can do chest x-ray. So when we do chest x-ray, you should know that in chest X-ray, it's not a very good investigation. So what happens in chest in effusion when we have chest X-ray? In the chest X-ray, you notice that this is the thorax. In the thorax, this is where you have the heart, and this is where you have the lung. So there is a space which is gravitationally most lowest or dependent. इस space को हम कहेंगे pleural recess. We will call these as, more precisely, we will call them as costophrenic recess. This is gravitationally most dependent part, these parts. These are called as costophrenic recess. This space. And this angle will be called as costophrenic angle. This we are going to call it as costophrenic angle, simply abbreviated as CP angle. As fluid accumulates, because of the gravity, it will always accumulate at the bottommost part. So first thing where I can have the evidence of fluid collection is fluid gets collected in this costophrenic recess. And as the fluid collects in the costophrenic recess, earlier when fluid was not there, remember, fluid on the X-ray appears as white or opacity. Air appears as black. So lung field would appear black, that you know with many X-rays. But as fluid accumulates, here it will no longer appear black. And this angle is no longer sharp. It become now blunted. So blunting of CP angle is the earliest X-ray finding on chest X-ray. So one thing we are getting is blunting of costophrenic angle. Okay, now as more fluid accumulates, the fluid starts accumulating, you know that fluid will always have a, as more fluid accumulates, fluid appears to have a higher level towards the axilla and relatively lower level towards the lung. So whether it is the optical illusion or it is because of the capillary action, irrespective of that, दिखता तो ऐसा ही है, it will always have a higher level towards the axilla and lower level anteriorly, lower level posteriorly. So this is going to kind of look like this. And when you see its topmost line, what does it look like? The topmost line looks like concavity, and this finding is called as meniscus sign. So second thing that we are going to get, this is called as meniscus sign. So second finding we are going to get is meniscus sign. So let me give you an image where we can see whether pleural effusion is there or not. Okay, just waiting for the image to download. Okay, so here we got an image as you see from the screen. Okay, so now pay attention to this side. Opacity, you can notice that opacity is because fluid is accumulated. And look at the topmost line of this opacity. It's not a straight line. It's not a straight line. It is concave line, slightly higher axillary level than anterior level. And this is what we call as meniscus sign. This is what we call as meniscus sign. So this is how X-ray is going to look like. So here also, even if you say, sir, I can't detect this meniscus sign, you can clearly notice that the costophrenic angle is blunted or obscured. Here, this side, costophrenic angle is sharp, clear, right? Because there is no fluid here. But when the fluid accumulation start, it will start here and it will make it blunted. So blunting of CP angle is early sign. As more fluid accumulates, I will end up seeing the meniscus sign. We will have a higher axillary level, lower anterior level, and slight concavity to the upper limit. We will call that as meniscus sign. So in this X-ray, we can notice that there is CP angle which is blunted, and we can also notice that there is meniscus sign. Okay, so is it difficult to detect the pleural effusion on X-ray? When it is moderate to massive, it's not very difficult. When it is minimal CP angle blunting, many of the times the doctors may miss it if they don't pay close attention to it. Usually the detectable limit for the chest X-ray is around 250 to 350 ml. If less than that fluid is accumulated, chest X-ray cannot detect. So the detection limit for chest X-ray the normal upright X-ray is usually 250 to 350 ml. So less than that, the chest X-ray will miss it. But if I do a lateral decubitus X-ray, I may be able to detect at lower value. Okay. So what is the other investigation I can do apart from this chest X-ray? We can also do ultrasound and CT scan. CT scan of the lung. CT thorax is the most sensitive investigation. It is most sensitive investigation because it can detect fluid even less than 10 ml. So it can detect fluid less than 10 ml also. Normal fluid is up to 20 ml. So normal fluid also gets detected by the CT scan. So can detect pleural fluid less than 10 ml as well. So it is most sensitive, but it comes with radiation exposure, cost. So it is something that we don't routinely like to do. So if you ask me, sir, what is the best investigation that I can do to pick up the pleural effusion? X-ray will pick up late, CT will pick up very early, but cost and radiation, let us find a middle ground. Middle ground is ultrasound. So USG chest is a very good investigation when it comes to pleural effusion because its detection limit is around 50 ml or even lower value it can detect. So it can detect pleural fluid less than 50 ml as well. So it has got good detection limit, does not involve radiation, and it's not very expensive either. So that's why right now this is the preferred investigation. Preferred investigation. If I'm expecting the pleural effusion in a patient, I would like to do the ultrasound rather than chest X-ray or CT scan. There's an added advantage with the ultrasound. What is that? If I detect and I want to aspirate the sample for the analysis, then ultrasound guidance makes the procedure more safer for the patient. So it's like I put a probe, identify fluid is there, put a needle, tap the sample for analysis. In one sitting, done. If I do X-ray, then again anyway I have to go for ultrasound guided pleural fluid aspiration or manual aspiration after doing all percussion based method to identify where is the fluid, which is not very safe. So ultrasound not only detects very small quantity at low cost without the risk of radiation, it also help you to guide for the site for pleural aspiration. Clear? So that's why it is the preferred investigation. Okay, I've got the investigation done and ultrasound has showed that there is fluid. It only confirmed pleural effusion. Why is there a pleural effusion? How do I get to know? So I can investigate further if I get to know that pleural effusion that we are seeing is exudative or transudative. At least if I get to know transudative, then these are the causes that come to my mind. It could be because of organ failure or decreased oncotic pressure in case of like kwashiorkor or nephrotic syndrome or cirrhosis. Or if I get to know that it is exudative effusion, then I can come to the conclusion that it is probably because of some degree of inflammation. It could be because of pneumonia, tubercular pleuritis, rheumatoid arthritis, or SLE or other inflammatory conditions. So is there a test that can help me to differentiate between exudative and transudative? Yes. Before we go there, let me tell you, what is exudative effusion? Inflammation की वजह से protein rich fluid going into the tissues or into the pleural space in this case. And what is transudative effusion? No inflammation involved. So low protein fluid is going into the pleural space. So I can do the pleural fluid analysis to detect whether it is exudative or transudative. So once I go for pleural fluid analysis, to decide whether it is exudative or transudative, we will follow a criteria which is called as Light's criteria. So what Light's criteria says is, according to Light's criteria, there are three parameters. Any one more than or equal to one criteria being met from the three listed criterias, more than or equal to one out of three criteria present in a patient is equal to exudative effusion. If all the criteria are absent, then it is transudative effusion. So to call it as exudative, three criteria that Lights has listed, any one of them meeting is enough. It is exudative. None of them are meeting, it is transudative. So what are those criteria? The first criteria is a ratio of pleural fluid protein divided by serum protein. More than 0.5. The second one is the ratio of pleural fluid LDH divided by serum LDH, more than 0.6. And the third one is, if I don't have the serum LDH done, I only have done pleural LDH, I don't know what is the patient's serum LDH. In that case, we will just look at the pleural fluid LDH, and the pleural fluid LDH, if it is more than 2/3 of upper limit of normal for serum LDH, मतलब serum LDH का let us say 220 upper limit of normal है for this particular lab, इसका 220 का 2/3 से ऊपर प्लूरल फ्लूइड में मिलता है, तब भी ये क्राइटेरिया सेटिस्फाई होता है. Now this criteria is what NEET PG MCQs are all about from the pleural effusion. So if it is about the practical exam, the questions are going to be all about examination findings. So what is Ellis shaped curve, what is cardiac resonance, what kind of auscultation sound you are going to get just above the level of pleural effusion. That's what your professors are going to ask. Maybe they will ask you causes for transudative and exudative. But if you get into the NEET PG, FMG or NICT exam, they're going to ask you to decide whether it is exudative effusion or transudative based on Light's criteria. So let us try to get this very clear. Next time, whenever you deal with MCQ on the pleural effusion, where you have to differentiate between exudative and transudative, you should not waste more than 10 seconds on that question. Don't say कि sir ये maths का question है, time लगता है. No, you should spend only 10 seconds. Now this ratio का मतलब क्या है? What is the meaning of this ratio? When the ratio will become more than 0.5? If the pleural fluid protein is more than half of serum protein. तो रेशियो बैठ के कैलकुलेट नहीं करना होता है. You don't have to calculate it. Just see how much is the serum protein and whether in the pleural fluid it is more than half or not. If it is more than half, ratio आएगा more than 0.5. So that is exudative. Once this ratio is satisfied, should I calculate the other ratios in the exam? No. What the criteria says? One criteria is enough to call it as exudative. तो यहीं पे मिल गया तो आगे देखने की ज़रूरत नहीं है. But okay, if I say ratio turned out to be less than 0.5, then I will go to the next criteria. I will see pleural fluid LDH and serum LDH. So if the serum LDH, like what is the meaning of this ratio? If pleural fluid LDH is more than 60% of serum LDH, the ratio will come as more than 0.6, right? So if that is there, then it is exudative. If I am not able to apply this criteria because I don't know the serum LDH, then all I have to do is whether pleural fluid LDH is more than 2/3 of the upper limit of normal for the serum LDH, then also it is exudative. So to make sure that we know these things better, let us take a question to decide whether it is exudative or transudative. So here we have a pleural fluid report of a patient available, which shows that this patient has got pleural fluid protein which is 4.6 grams per deciliter. This patient's serum reports are also available. Serum protein is 8 grams per deciliter. And this patient's pleural fluid LDH is 190 units per liter, and this patient's serum LDH is going to be 220 units per liter. And now the way they are going to construct the MCQ on this is, which of the following is least likely cause for pleural effusion in this case? So first option is tuberculosis. Second option is Pneumonic effusion. Third option is rheumatoid arthritis. And fourth option is nephrotic syndrome. So first let us determine whether it is transudative or exudative. So what is the first Light's criteria? Pleural fluid protein and serum protein ka ratio more than more than 0.5. Basic meaning is, if pleural fluid has protein more than half of what is there in the serum, this criteria will satisfy. So here serum protein is 8 gram. So for me to satisfy this criteria, how much protein I need in the pleural fluid? 4 is enough. There I will get 0.5 as the ratio, half, 50%. And if I get 4.1, it will be more than 0.5. So here how much I am getting? 4.6. If you want, you can take a calculator and calculate, but it is, I'm sure it is going to be more than 0.5 because the pleural fluid protein is more than 50% or half of the serum protein. So the criteria is satisfied. Should I look at the LDH now? No, I don't have to waste my time on the LDH. Many students in the MCQ based exam, they keep on calculating all of this. No, a criteria kafi hai. Done. This is exudative effusion. Let us say that this information is not there or this did not satisfy. Let us say this is 3.6. Definitely ratio will be less than 0.5. Then we will apply the next criteria. Then I will see LDH. First criteria not satisfied, I will see second. In the second, if I have my pleural fluid LDH 60% of serum LDH, then I will get the ratio more than 0.6. So 60% of 220 will be 60% of 100 is 60, 60% of 200 is 120, 60% of 20 is 12. So if I get 132 or higher, 132 will give me a ratio of 0.6, and anything higher than 132 in the pleural fluid will give me a ratio of more than 0.6. So here it is definitely going to be more than 0.6. This way or that way, we know that it is going to be an exudative effusion. So diagnosis here is exudative pleural effusion. So now basically the question's meaning finally turns out to be, which of the following is not a cause for exudative effusion? So in tuberculosis there is inflammation. So again remember, impairment in hydrostatic oncotic pressure, you are thinking of transudative. Inflammation involved, you are thinking of exudative. Tuberculosis, inflammation hai. Parapneumonic pneumonia, inflammation hai. Rheumatoid arthritis, itis, inflammation is there. Nephrotic syndrome, no inflammation. So these three are going to cause exudative effusion. Nephrotic syndrome is going to cause transudative effusion. So these are all exudative. And this is in nephrotic syndrome, you're losing albumin in urine. So you have hypoalbuminemia, you have low oncotic pressure. So it is going to be transudative effusion. This will be transudative. Again, a very important pro tip for those who are preparing for the entrance exams. अगर ऐसा क्वेश्चन मेरे सामने खुलता है तो आई विल नॉट इवन वेस्ट 10 seconds. आई विल जस्ट टेक 1 second टू आंसर एंड मूव ऑन, बिकॉज व्हाट आई नीड टू डू इज आई जस्ट हैव टू सी द ऑप्शंस, एंड ऑप्शन में पिक द ऑड मैन आउट. क्वेश्चन कुछ भी पूछ रहा हो, ऑड मैन आउट विल गिव मी द आंसर कि ये नेफ्रोटिक सिंड्रोम ट्रांसुडेटिव है, ये सब एक्सुडेटिव है. So even if I don't calculate all of this, I will still pick the odd man out and I will reach the right answer. ऐसा एक और क्वेश्चन है जहाँ पे 3 ट्रांसुडेटिव के कॉजेस मेंशन किए गए हैं और 1 एक्सुडेटिव के मेंशन किया गया है. देन वॉट एवर इज द क्वेश्चन एग्जामिनर आस्किंग, एक्सुडेटिव विल बी द आंसर. कैसा ही और एक क्वेश्चन है जहाँ पे दे हैव मेंशनड some values and we come to the conclusion that it is transudative, and then the examiner is asking which of the following is not known to cause this condition, and option 3 transudative हैं और एक exudative का like tuberculosis is mentioned, बाकी CLD, CKD, all of those are there. What should be my answer? Pick the odd man out. So in the exam you can easily solve these questions by picking the odd man out. If you want to be a little doubly sure, take the ratio quickly. Mind में करना है calculation, no like taking too much of time. If pleural fluid protein is more than 50% of the serum protein, done 99% of the MCQs asked so far always had the first criteria itself met. You don't have to look at the LDH. You got your answer, whether it is exudative or transudative. Move on to answer the question. Clear? So let me summarize what we have discussed so far today quickly. What is pleural effusion? Abnormal collection of fluid in pleural cavity. Normal value is less than 15 to 20 ml. Anything more than that is abnormal. Does not mean that patient will always become symptomatic. So what pushes the fluid into the pleural cavity? It can be either because of imbalance in exudative or transudative, imbalance between hydrostatic and oncotic pressure. Imbalance always causes transudative effusion. Or there can be inflammation. Inflammation always causes exudative effusion. We have listed the causes for transudative and exudative effusion. Then we looked at the clinical features. If there is minimal pleural fluid, patient will be asymptomatic. But when it is massive, patient will definitely become moderate to massive. They will present with symptoms. What are the symptoms? Shortness of breath is going to be one of the symptoms. Apart from that, we will have a lot of examination findings. What examination findings we are expecting? As pleural effusion happens, fluid starts collecting in the space, pushes the lung up. Some part of the lung gets collapsed under this pressure by the pleural fluid. And when lung gets collapsed, some part of the lung starts overworking to compensate for this lost part of the lung. It becomes compensatorily hyperinflated. So we create three levels: fluid, solid, increased air, and then normal air. So when we examine, the fluid gives dull note, this collapsed area gives dull note, the upper limit of the dull note or upper level of the dull note goes on ascending towards the axilla and again descends posteriorly, giving rise to what we call as Ellis S-shaped curve. Just above this level of dullness, यहाँ पे dull, just above this level of dullness, there is a band of resonance because of hyperinflation. We call it as Skodaic resonance. And when we go to auscultation, fluid is not a good conductor of sound. We will have decreased or absent breath sounds. But just above this, the consolidated lung is a very good solid lung, good conductor of sound. And because it is solidified, there is no air, there is no alveolar aeration, there is no filtration by the alveoli. The sound produced in the bronchi directly comes to the stethoscope. We call that as bronchial breath sound. Above that, alveoli are there, they are aerated. So the normal lung and hyperinflated lung will give rise to the normal vesicular breath sounds. If the fluid is massive, it will push the trachea to the opposite side, lift the sternocleidomastoid. We will call that as trail sign. In pleural effusion, trail sign is positive on the opposite side of the effusion, because अगर right में effusion है तो trachea will be pushed to left sternocleidomastoid will become prominent. But if a lung collapses, it will pull the trachea towards its side. Like इस side का अगर lung collapse होता है, it will pull it. So in a collapsed lung, if पूरा lung collapse हो रहा है and trachea is being pulled, the trail sign will be positive on the same side of collapse. But effusion में opposite side. Right में effusion, left में trail sign positive. Left में effusion, right में trail sign positive. Collapse होता है, अगर right का collapse, trachea will be pulled to right, trail sign positive on the right itself. Okay, this is something that examiners try to confuse you with. Have the clarity. When the lung collapses, it pulls the trachea to the same side. So trail sign will be positive on the same side. When effusion happens, it pushes the trachea to the opposite side. So trail sign will be there on the opposite side. Okay, now for the diagnosis, X-ray, CT and the ultrasound are available. X-ray's detection limit is 250 to 350 ml. So till that time, X-ray may not detect it. CT's detection limit is few ml, less than 10 ml also it can detect, but it involves radiation and cost, so it's not preferred. The middle ground is ultrasound. Ultrasound does not involve radiation, can detect fluid less than 50 ml and also gives guidance to the pleural tap. So that's why right now preferred investigation is pleural ultrasound of the chest. Once with the ultrasound I have confirmed the diagnosis. To know the etiology, I have to go for pleural fluid analysis. For that we will tap the sample, ideally under ultrasound guidance. And once it is tapped, we will analyze in the lab. We will apply the Light's criteria to decide whether it is transudative or exudative. In the Light's criteria, pleural fluid protein divided by serum protein ratio more than 0.5 is exudative, or pleural fluid LDH and serum LDH ratio more than 0.6 is exudative. If I don't have the serum LDH values available with me, I can see how much is there in the pleural fluid, and if this pleural fluid LDH is more than 2/3 of the upper limit of normal for serum, तब भी ये exudative है. To call it as exudative, तीन में से एक criteria satisfy होना काफ़ी है. We don't have to meet all the three criteria. If all three criteria are negative, then we will call it as transudative. Okay, so once we have decided whether it is exudative or transudative, reaching the diagnosis becomes easy because we already know what are transudative causes, what are exudative causes. So that's it from me today. I hope today's discussion helps you to deal with your professor's question in practical examination, write 5 or 10 mark question in your theory, and also 1 or 2 important NEET PG MCQs that are going to come. I will share this note on the PW MedEd Telegram channel, and if you find that you're not able to trace this note, you can ping me on the Instagram and I'll share it with you. So, okay. Study well, guys. I'll see you in the next class. Till then, have a good time. Bye-bye.